Hello, everyone, and thank you for joining us today. Happy Sunday, and happy last day of the ThyCa conference. Today we have Dr. Myssiorek, who is an otolaryngologist at Bronx Care Health System in the Bronx. He'll be talking about the complications of surgery. He is the author of numerous articles on thyroid cancer surgery and other head and neck surgery. A graduate of NYU School of Medicine, Dr. Myssiorek did his internship at Lenox Hill Hospital and was chief resident at New York University, Bellevue. He is the author of numerous articles on thyroid cancer surgery and other head and neck surgery. Dr. Myssiorek is a ThyCa medical advisor. Take it away, Dr. Myssiorek. We're so excited that you're here with us today.
So welcome me aboard. I'm seeing the question and answers while I was getting my introduction. I'm a bit overwhelmed. People using abbreviations that I don't use. So let me just start. I think preliminarily I need to have a slideshow, which will not be long. And at the end, I will do what I do every year. And I've been doing this, ready for this, for 24 years with ThyCa. And the only other person, to my knowledge, that has been doing this for 24 years with ThyCa has been Gary Bloom. So let me get on with my slides. And let me make sure I'm doing this correctly. A lot of this slide bank came from my friend, Dr. Agrawal. I am not Dr. Agrawal, but these have been used by me in the past. So when we talk about complications of surgery, I'm not going to talk about complications of the other treatments. Strictly, I'm a surgeon. And when it comes to other treatment, I prefer to have experts doing that. The same, they would probably rather not be doing the surgery. So it depends on where we go with thyroid surgery. In my era of training, just before I started, everyone was doing partial thyroidectomies for this disease. And then in my era, everyone was doing total thyroidectomies. The main drawback was that a lot of people were doing poor thyroidectomies. We codified some of the rules, and now we have pretty much standard procedures, although that's changing as well now. But many of us are very comfortable with total thyroidectomy, and those of us who are older realized that we didn't need to do total thyroidectomy for every group. The basic rules are, and by the way, this does not apply, say, to the non-well differentiated thyroid cancers. Obviously, anaplastic thyroid cancer and medullary thyroid cancer follow a whole different set of rules. But a small thyroid cancer, particularly one that does not go out to the edge of the thyroid gland, can be treated with a lobectomy and isthmusectomy. If there are no evidence of lymph node metastasis, it's an extremely righteous operation. When they get bigger, and this is always a little bone of contention, or if there is gross extrathyroidal extension, we extend the operation to a total thyroidectomy. In obtaining informed consent from my patients, who, by the way, some people call clients, it makes me a little crazy, just as I don't like being called a healthcare giver. It's tough doing this kind of talk when you don't have a live audience who are able to either laugh or boo at you. We do it for clinically apparent metastatic disease. And finally, if there's metastatic disease to distant sites and we want to employ radioactive iodine, we have to get rid of as much radioactive avid tissue as we can. Recovery. Now, it's really interesting. This is my experience. It may not be your experience. Those of you who are in this room, I'm 67. I'm a little intimidated. But of the 67 of you, you're not here because you had a perfect result. And this is something that intrigued me the first few years that I was a ThyCa speaker. I actually learned this lesson from one of my daughters, and she doesn't have thyroid cancer, but she has something else. When people join chat rooms for something that they need or information that they need, or just to get, hey, am I alone in this journey? ThyCa is indispensable. On the other hand, the person who had, I guess, the textbook perfect result generally doesn't join ThyCa. So we like to address the people who are here. There's a sore throat involved. I don't know. It's not a week in my patients. It's usually 2 or 3 weeks. There's some fatigue and there is some neck swelling, and there may be hoarseness. And of course, one of the complications is a depressed calcium. I'm going through this in a rapid phase because I want to get to the questions, of course. The recurrent laryngeal nerve, and there's been a lot of information about this lately. I know Dr. Randolph in Boston has been championing neural monitoring, which I support nearly 100%, but I'm of the era that trained that said, if you can't find the nerve, A, you shouldn't be doing the surgery, and B, you should not depend on a device to find it for you. In fact, most of the devices depend on you finding the nerve and then stimulating it to make sure that it is the nerve. It's electrical confirmation. Overall, there's about anywhere from 0, which I don't believe, to 7% permanent paralysis. And there's about a 0 to 11% transient paralysis. And the 11% is probably an underestimate. I know one of my friends down in Augusta tested every single patient in the recovery room after thyroid, and 18% of them had some form of paresis, which of course went away by the time they were home. But still, it tells you why the data may not be as pristine as we'd like. The superior laryngeal nerve, that's what SLN stands for, is responsible for your ability to sing and change your pitch and your loudness, or what we call projection. It's 3 to 5% of the time it's permanent. In a study basically run by ThyCa, we found that half the patients, at least that were in ThyCa, had this complication out of surgery. If you're not sure if you have it, get in the shower, turn on the water, and sing something by Toto or sing Bohemian Rhapsody. You'll know right away if you don't have this range. Other complications then stem for additions to the basic thyroidectomy, which include neck dissection, whether that's a standard central neck dissection, and this completely depends on whether or not you think there's disease there, or if it's already spread and you need to clean out part of the neck, or I should say we need to clean out part of the neck. Again, from the neck dissection, we usually put a drain in. We have about 1 to 2 week recovery. There is, when you do a central neck dissection, one of the landmarks you look for is the entire length of the recurrent nerve, and you stay medial to it or between the two recurrent nerves, and you take out as much tissue as you can. The problem is you can sometimes, you meaning the surgeon, can sometimes inadvertently, I can't use the word accidental, inadvertently remove a parathyroid or devascularize it, in which case the patient may have a lower calcium. So there's also been, and I always have trouble with this, the definition of a high volume surgeon. The last time I heard a number was 50 per year. Then I heard 30 per year. I think those numbers really, I mean, I understand why they publish these numbers, but there are some phenomenal surgeons out there who do 20 a year, and there's some phenomenally bad surgeons who do more than that. We rarely see a hematoma. I don't know if my arrow is showing up here, but the hematoma is an uncommon complication. But hypoparathyroidism, of all of these, this is the one that actually terrifies me, because I have seen significant hypoparathyroidism, and with a 13% permanent rate in some of the older series, that's awful. I mean, many of you who may be in this room will have, if you have permanent hypoparathyroidism, you know how many medications and how often you have to take them. So I really don't want to dwell on this because I suspect this is going to come out in some of the questions, and if it doesn't, better for all of us. This number, the 18 to 77% shoulder weakness, is, I think, a number that has been gleaned from patients going for this kind of neck dissection, not for thyroid cancer. Chyle leaks are important, and they do happen if you have a left-sided neck dissection, because a lot of the lower nodes, the level 4 nodes, are where the chyle duct is in the left neck, and it's not visible. So you can actually sometimes cut it, and sometimes you will see what looks like fatty tissue or milk in the wound. And if you see that while you're operating, we implore people to try and find it and close it off, not with a cautery, but by actually sewing it closed. I have yet to see a Horner syndrome in my practice. They are reported. This lovely creature, I was very close to this, not close emotionally, I was very close physically to this animal, and I don't think she was happy, because what you don't see behind her is her little, I guess whatever you call a zebra colt. And with that, I'm going to end my slide presentation and open this up to questions and answers. And I'm not exactly sure how we're going to be doing this. Good afternoon, Jeffrey.
Okay, so our first question, what are RAF complications?
I want to know what, this is right in the middle of my screen. I'm not sure, what by RAF do you mean by radio frequency complications? Yeah.
Let's see if let's see, Edward, if you are able to give us a little bit more information in the Q&A, we'll give that to the doctor. So in the meantime, we'll skip to the next question while Edward is giving us more information. This question is from Jackson. During a thyroidectomy, is damage to the RLN more likely if the nodule is pressing against it?
I'm choosing, by the way, not to answer these by email, but live, because I can speak a whole lot quicker than I can type. The answer is yes. The more dissection we have to do, like to take the nodule off or move it away, or even if it's just simply pressing on it, it still requires a degree of retraction and dissection. So, Jackson, I'm not sure if that's your first or your last name, but during a thyroidectomy, damage to the recurrent laryngeal nerve is probably a lot more likely if the nodule is at the nerve. I know that's when I have two of the places where I have struggles. And the trick for the surgeon is just to be patient. You don't have to rush things through. And sometimes there's increased vascularity around these nodules. So it takes a little bit longer, and you cannot use devices, for instance, that will seal off these bleeders, because they can damage the nerve. In cases like this, I am very grateful for using nerve monitoring, but I don't always monitor my patients.
Okay, thank you. So Edward further wrote, yes, radio frequency ablation or abolishing.
Okay, so first of all, can I be heard?
Yes.
Okay, good. The answer to that is, I think radio frequency ablation is, at this time, is being used for very specific cases. I think that if you can get to a nodule surgically, you should get to a nodule surgically. There is problem with overheating. There is a problem. One of the complications is a nodule may be left behind near a recurrent nerve or near a vital structure for the reason the surgeon didn't want to take it out, right? The surgeon was afraid he was going to damage the nerve, or she was going to damage an artery. So when you have a case like that, if that's the remnant that's been left, I want to move my window here. Yeah, over here. That's better for me. I can't tell if my nose is running. The answer is that if it was on the nerve to begin with, and it's a small nodule and you're going to ablate it, those nodules heat up. That's how you're basically killing them. So the answer is the complications are the same as they are for surgery, but the selection of the patient, of course, is critical. Is this a single nodule far away from something important? And by the way, very, very, very important, does your hospital and or doctor have the correct personnel and equipment to do this? Obviously, if you don't, you either refer the patient out, or you maybe attack it surgically. It's not that I'm not a big fan. I do not have a lot of experience.
Okay. So the next question, what are the most common complications in a complete thyroidectomy? How are they different from the ones of a first surgery?
Oh, that's a really good question, and I like that because I'm looking at it independently, but I will never publish these results. The the person who has an immediate, now we're talking about who has a total thyroidectomy straight out of the gates. Well, you obviously open up both recurrent nerves, both superior laryngeal nerves, and all four parathyroid glands to complications. So the person who's only had a hemithyroidectomy or a subtotal thyroidectomy literally has half the risk. Also double the risk of bleeding, since you can bleed from either side. We're seeing probably more and more patients surgery halted because during neural monitoring, the doctor loses the signal from the neural monitor, and the prudent decision, again, this is my opinion, I don't know that I represent anybody in particular, the prudent decision is to stop and wake the patient up and see if indeed you've damaged the nerve. Because I'm sure somebody in this room, maybe more than one, have suffered from a bilateral vocal fold paralysis. And most of the time, those patients end up requiring a tracheotomy. And tracheotomy is no fun. And believe me, I'm not making light of this. It's something I'd rather avoid. And given a choice between giving somebody a tracheotomy that they weren't planning on having, or waking them up and giving them a second surgery, I'm always going to choose the latter. Having said that, that's one complication. That is, you cannot get bilateral vocal fold paralysis if you only operate one side. If you operate both sides, the chances of devascularizing or at least traumatizing the parathyroid glands, all four of them, is of course ever present. And for me, that, I told you before, that's one of my dreaded complications. It terrifies me. It's a strong word, but I would do anything to avoid it. Having said that, the patients, in my experience, when we have operated a completion thyroidectomy, meaning the secondary operation, we never ever have hypocalcemia in the patients. And my thinking is that whatever parathyroid devascularization or compression or whatever we did to the side that we operated has had a few days to weeks to months to recover. And therefore, I'm only traumatizing the next two that are up on the block. And hopefully I'm not doing that either. I've been blessed. I don't take credit for much that I do. I've just been blessed with my patients having pretty good outcomes in regard to this. Now that I've said it, of course, the next person will have a complication. But I will say that the way to avoid it, the big one, is hypoparathyroidism. And people were worried that the secondary operation would, because of scarring, cause a harder dissection. That's not entirely true. And if you mind your own business during the first one, i.e. you say, I'm not doing anything more, don't, to the word to the surgeon, don't explore the side you're not operating. It doesn't do anybody any good. And I hope that was a lengthy but tedious answer.
Thank you. The next question is, I'm a professional woodwind player and music teacher, so the vocal complications are my biggest concerns. What are some specific precautions that I should ask my surgeon to take, or specific ways to express these concerns? Thank you.
Wow. Well, I'm not sure. I've not heard of complications with any of the wind instrument players, but voice, obviously, there's, I have to be careful. I'm going to answer you as a surgeon, and I will tell you, I have friends who are chefs, and they usually say, you don't complain about the food until after it's served, because otherwise your waiter is going to be bringing you something you weren't planning on. So I think when you tell your surgeon straight out of the gates, don't hurt my vocal folds, you're going to set up not a wonderful doctor-patient relationship, but you certainly should say, hey, listen, I am a music teacher and voice is very important to me. From there on in, you can ask anything you want. Reasonably, if your surgeon gets informed consent, they're going to tell you that your vocal folds are not the nerves, your vocal folds are at risk. The nerve that allows you to sing, that's the big one, the Amelita Galla-Curci outcome. That's the one that we damage most without knowing it. And when I say damage, I should probably temper my words. We hurt it, and it does recover. We know it recovers at least 90% of the time, but it's a very small nerve. Maybe 6 human hairs make up the size of that nerve. And in a very big goiter, you may not see that nerve. It's going to be tucked behind something large that you're trying to manipulate. So, in doing that, I mean, the only thing that you might say to the surgeon or ask the surgeon is, do you use nerve monitoring? If your surgeon says no, it's not, he or she will probably say, this is why I don't. He or she may say, do you want me to use it? I'll use it. And I think nowadays most people are using it. And I'm just sort of not totally committed. So I hope that answered that question.
Thank you. David wanted you to know that as a member of the live audience, he was chuckling.
Okay.
And when you said it was hard to not see faces. So let's see.
Well, my son-in-law wants me to do live mic in Philadelphia as stand-up, which I used to do in college. So I'm not sure that would be a wise idea.
So, doctor, do you recommend intraoperative neuromonitoring of the RLN in every total thyroidectomy, and why?
Great. Well, I think I just partially answered that. The answer is what works in my hands. Look, I'm an old dude, and I trained during a period where we didn't have all the little toys and bells and whistles that we have now. And the answer is, it can't hurt, but you shouldn't depend on it. I will say this much, that if you can't find the nerve, the whole purpose of using nerve monitoring isn't to find the nerve, it's to confirm that you found it. So if you were hiding in a room in your home, and we searched every room but the room you're in, unless we get a dog sniffing for you, we're not going to know that you're in that other room. If we open up the door to that room and I have a picture of you, I'll know it's you. So if for certain cases, I should give you the absolutes. On patients who are doing thyroidectomy, say for hyperthyroidism, where there's a lot of scarring and a lot of vascularity, I always use it, because that's one where you might lose the vision of the nerve. The other ones I use it for are redo operations, and the other ones I use it for are where on the CAT scan that this is very, very big, if you had a CAT scan, of course, or the ultrasound. And I think those are the main reasons. Oh, obviously, if a patient had RAI or any form of radiation, I would still rather have the nerve monitor. And then there's one group that people are now advocating nerve monitoring for, and that is the morbidly obese. Part of that has to do with anatomic considerations. It's very difficult in some of these folks to get their necks extended. So you want to have a nerve monitor because you're getting to see less of the field. I hope that answered the question. Again, I'm going to say this for every question. I hope that answered the question because there's no immediate feedback.
Okay. So the next question, had total thyroidectomy in 2020 and left laryngeal nerve, was resected, ATC. I've had thyroplasty at Vanderbilt, which has been successful. Do you foresee the need of another procedure in the future, or should I expect this to hold forever? 3+ year ATC survivor. Is that?
ATC survivor, God bless you. if the people in this room could applaud you, they would be. I am. Really, you are the reason we wake up in the morning. Now, I was just meeting with a couple of days ago with Dr. Netterville from Vanderbilt, and he is basically one of the big champions of thyroplasty. I obviously don't know if that's who your surgeon was, but the people at Vanderbilt are top flight, and I doubt that you'll need another procedure. If we're talking about the voice holding up, the answer is absolutely it should hold. A lot of stuff happens over 3 years. You're going to atrophy a bit, but you made my day. You had a good outcome, if you will, from both procedures. God bless you. I hope that answers your question. It should hold.
Okay. I have both RLN and SLN, very hoarse and broken speech and cannot change pitch, stuck in low pitch. I'm 5 weeks post-op of total thyroidectomy. Scopes last week show everything normal and was told this was not related to surgery and it's spasmodic dysphonia. I have seen 2 speech therapists and neither know how to treat. Do you have any thoughts?
Sure do. And this is, speech therapists are not going to be able to answer this question for you. I have a degree in speech therapy, so I'm not being condescending or anything like that. You need to see, I think this is from Bridget, you need to see a true laryngologist. The diagnosis of spasmodic dysphonia following a procedure which can lead you to have both of these findings is unusual. Also, and most importantly, is it's really early. Did you say, I'm going by what's written here, you had 5 weeks post-op. You're not out of the woods yet. You're not, your wound is probably still swollen. I don't think you should be labeled with spasmodic dysphonia as of yet. This is, if you wish to privately get back to me, which I think we can do, I would be happy, if you haven't done this already, happy to direct you to somebody in your area who does vocal work, because spasmodic dysphonia is a very, very specific diagnosis for those in the audience, the listening audience. It is, and I'm not going to mimic it because it's just, it's a very choppy voice and it is low frequency. But it doesn't necessarily mean that this is from surgery, and it doesn't necessarily mean that it's spasmodic dysphonia. I would really back off that diagnosis at 5 weeks. The other thing is you'll probably end up getting a radioactive iodine. This sounds like it was extensive surgery, but take a step back, and somebody will be able to get you in contact with me. Please, I hope it wasn't me who did this. And we'll take care of you.
Thank you. I'm going to skip that next question and go to, as a person diagnosed with post-op Horner's, what nerves usually cause that?
Wow, where is this one? I'm not seeing the question. The answer is post-op, but I like the selection. The post-op Horner is from a sympathetic nerve injury. The sympathetic nerve runs in a plexus, meaning it's not just a single nerve. It's a group of nerves that surrounds the common carotid artery and goes up, usually the the internal and external artery, and they innervate the pupil and they innervate the eyelid. If you're paying close attention, I actually have a light version of it on this eye. I don't know why. But there are now eye drops that will mediate a lot of the findings of Horner on one side. It's not a dangerous complication. It's just that it usually implies that a bigger dissection was done. So I'm simply saying that that specific nerve is the sympathetic nerve. It has some really complicated pathways, which I'm not going to give you over this thing because I don't think we have enough time, nor do I know that I can do it straight out of my memory right now. And the big one is the lid ptosis, because that's the one that's noticed by everybody. That's where your eyelid falls. And frequently at night when I'm reading, I'm pulling this eye up now. There is surgery to relieve it. I've spoken to a number of people who've had it and it doesn't last. So I'm holding off. But I don't have a Horner from surgery. I'm just lucky, I guess.
Okay, thank you. Let's see. If we still have hoarseness years after surgeries, are there things we should do other than voice therapy?
Yeah, I mean, again, it depends on the degree of hoarseness. There are now troops, if you will, of laryngologists, people who do nothing but voice day in, day out. I'm sure they have other new secrets that I'm not completely aware of, but I do have most of them. I would say that I would seek their attention. I would not necessarily seek a voice therapist first, because that may be the advice you get from the laryngologist, but we are capable now of fine-tuning a voice box to the point where we can get it. I'm not going to say normal. Nothing is ever normal after a surgeon hits, but darn near normal. I know that Dr. Netterville, I'll bring up his name again, taught me a little trick, and that is when we do our vocal implants, we have the patient sing in the operating room, and it's oh, I have to watch my language. It's pretty darn amazing to watch these people, and your operating room staff always cries because they're there for a minor miracle, and we all appreciate what it's like to give somebody back something they don't have. So my advice would be to see a super specialist. You know, your average otolaryngologist may be able to deal with this, but if it's just a little bit, I want to tweak this, I want to adjust a little bit better, then you want to be in the hands of somebody who does this daily.
Okay, thank you. How common and how significant are nodule adhesions to the laryngeal nerve and trachea? Sounds significant.
I don't know. My favorite answer, I don't know. I don't really distinguish them when we're in the operating room, because every step is important and every step requires attention, and there's no glide path in thyroid surgery. There's one place where you can take the strap muscles off the thyroid with one finger, and it goes pretty quickly unless you have scarring. It's a really trite answer. I apologize, but it's only significant if it's significant. I'm sorry about that really short answer, but I don't I don't think I don't distinguish patients that way. I'm much more worried about blood vessels within, say, Berry's ligament that I accidentally get across.
Okay. Thank you. Can damage to the RLN repair itself, or can it be repaired by treatment or surgery?
These are great questions. They're great questions because I can actually answer some of them. The standard answer is we've asked this question in all sorts of rooms where people are trying to set up guidelines, and our current guidelines say that if you transect the vagus nerve, for instance, in the operating room, or the recurrent nerve, you do sew it back together. But I hope you'll be able to see my incredible graphic here. If this is a nerve, I have a lamp on. If this is a nerve, and this is the nerve when it was intact, and we divide it, if the nerve bundles don't hook up to the nerves that they should have hooked up to, we get a mismatch. So when your brain is sending a signal to your larynx, your voice box, to close, to make voice, you may be stimulating the nerve that tells your voice box to open. So in those cases, it's not a great matchup. But the bottom line is 3/4 of the nerves go to one specific muscle group, and they're the ones that basically bulk up your larynx and allow it to more or less occupy the space all the time. I'm not being very clear. If your vocal fold is stuck in this position, all you need is this one contacting it. But if it's stuck out here, this is what you're going to get, that breathy voice. You're going to get that really harsh voice. What we do is we give this one a little nudge. And that nudge sometimes can come from simply hooking up the nerve to itself. Generally, I don't like repairing nerve disorders, even when I know that I made a mistake and have cut the nerve. Of course, I inform my patient that I did. And if that happens, I will wait some time to see what compensation the patient can make without me interrupting their lives again. And in those cases, I've been satisfied 60% of the time, and the other 40% we operate. I hope that answered.
Okay.
May I ask, can I cut in line here?
Yes.
I have a question here from Rita, and I'm going to read it out loud, at least what I can see. I had a right neck dissection in 2010, a total thyroid in 2008, and still, it says with overuse like crocheting, etc., have neck pain. Is there anything you can do about that? Well, I'm going to answer that aloud. And the answer is, if they damaged the spinal accessory nerve on that neck dissection, it means that you have a shoulder drop. And the shoulder drop in acts like crochet, I don't crochet, combing your hair, I still have hair, or fly fishing, I go fly fishing, and I have arthritis of this shoulder. So casting has become a recent lack of pleasure. There are very few things you can do short of rehabilitating that shoulder, but at 13, 14 years out, that's a tough one to fix. Generally, suspending your shoulder, meaning wearing a sling when you're not using it, will take some of the pressure off that, because your weight will be on the weight of your arm is constantly pulling on your shoulder. But Rita, if we're talking about neck pain, I don't know that that was necessarily caused by the neck dissection. Neck pain is a very specific orthopedic problem. You did get radiation, I'll presume, and that also could be causing pain. So I don't know. Again, there's no feedback here, so there's no way to tell if I've answered a question.
All right.
Oh, by the way, Veronica, it looks like there's a lot of Q&A. I'm looking at my thing, so I'm apologizing to the people that I'm not getting to, and there's nothing I can do but go one at a time.
Yes. So we have 26 questions in the queue right now.
Yeah.
Do you have another choice, or shall I keep going?
Keep going.
Okay. Let's see here. If you're willing to talk about tracheostomies, I have a Montgomery number 6 trach, and I'm having problems with the speaking valve both falling off and not opening enough to let in all of the air I want. Do you have any suggestions?
David, great question. Tracheotomy is something that, for those of you who don't know, sometimes people with severe thyroid disease or laryngeal invasion or bilateral nerve involvement require tracheotomy because they can't breathe without it. Their vocal folds are stuck in the midline position, which is great for voice, and it's actually great for eating, but stinks for breathing. And so we have to do a tracheotomy, and the valve, instead of being your vocal folds, is now a device on the end of the tracheotomy tube. I'm going to start with, you have a number 6 Montgomery. I work mainly with Portex, but the 6 usually refers to the inner diameter of the tube. For a grown man, David, I think I'll assume you're a grown man. Probably not a safe assumption. 6 is pretty small, and you're probably generating a whole lot of pressure that keeps blowing the valve off. The other thing is you may not be putting the valve on tight enough. If you're working with a good speech pathologist, they should be able to solve very rapidly. It might, in your case, mean going up to a bigger Montgomery. On the other hand, it's more work. So this is something I would pursue, because the one thing that the speaker valves does is it allows you to regain some of the function that was stolen from you. I'm sorry about my dramatic use of some words, but I feel strongly about cancer survivors, being one myself. So, when people talk about us, they get a little sensitive. I hope that answered some of your question.
Okay. Let's see here. What is the prevalence of lymphedema with neck dissection for metastatic PTC in lateral neck? Is that
These questions are off the charts great, sometimes because I don't even think about these things. The answer is, by definition, every single patient should have it after the surgery, because done correctly, you've interrupted the lymphatic flow out of the head to the neck and from the neck into the chest. So if we do our job correctly and we give some sort of radiation, those lymphatics should really be mostly destroyed. Having said that, not everybody gets edema, visible edema, but everybody does get some edema. In my particular cancer surgery, I'm very aware of where my edema is. I did not have throat cancer. The bottom line here is that I think that if it's extensive, a real lot of edema, it implies that you had a real lot of disease and a real lot of treatment. For some reason, our standard neck dissections, lateral neck dissections for well-differentiated thyroid cancer are usually limited. In fact, in the days of yore, we used to do berry picking, meaning just pick out the lymph nodes that are enlarged. And to date, no one has shown that that's really a bad thing to do. And it left many lymphatics around. The downside of that is that it left some disease around. The other side of that, though, is we don't know what it means to have a little bit of thyroid cancer. I know I'm giving rapid fire stuff here. So ultimately, that argument is never going to be one on a patient level. It's going to be one, if you will, in a statistical level, i.e., my radiation is better than yours because we see less disease, but no one knows what it means to have a little disease. And those of you who are in the room who still have disease know that it's not hurting you. Well, it's not killing you, I should say, but it sure as hell is scaring you. It's the same thing in men who have prostate cancer. They don't know what it means to have a little bit of, if you will, a touch of prostate cancer. I love that expression. Touch somebody else. I think that the answer to, I'm getting drowned all the way back, is edema is a reflection of the extent of disease that you had and the extent of the dissection that you had. And it's not an unfair trade-off. A lot of people are going to physical therapists who know how to do deep massage for edema. It's not just rubbing. And it's not just pushing it down to the chest. You really have to have a deep knowledge of what's going on and probably an appreciation of how much surgery was done.
All right, let's jump on to another question. So the next question is, I have occasional trouble swallowing normally. I have to swallow only while facing forward and by tilting my head down slightly. If I don't follow these guidelines, I often choke or have to swallow multiple times to actually complete the single swallow. My endo has said I have scar tissue there. Is this a fairly normal complication? And what interventions are available?
Okay, I don't know how to get the next piece of information back from the author of that, but when was the surgery? I mean, I don't know, is it in the queue here? Will I see it if I get a chance to read it?
Yeah,
all the way to the bottom. And Penny, if you can type into the Q&A your response, that will help us. And in the meantime, we can go to the next question while we're getting that information.
Sure thing. Curious if you've heard instances similar to my own. Post-thyroidectomy, left mod, radical neck dissection, had total voice loss. Interestingly, my voice came back within several hours of receiving RAI and remained for 36 hours, then no voice again. Now documented paralysis, right RLN.
Mm-hmm. Wait, but you said you had a left total.
Says thyroidectomy, left mod, radical neck dissection, and had total voice loss.
But they're telling you it's the right nerve that's out?
Oh, I don't know.
That's what it sounded like when I heard. But in any event, I'm sorry, what was the time on that? I'm getting confused here. How long ago was this?
So they said it doesn't say how long ago it was. This is a different question. Their voice came back within several hours of receiving REI and remained for 36 hours. Then they lost their voice
Yeah.
again. And it's
What's
now been documented that they have paralysis on their right RLN.
right, Arlen? Well, it's a lot of stuff to unpack. I love that expression. Uh, when people get better after any sort of brief therapy, um, that what it implies is that something swelled, and likely if it's the right recurrent nerve, your right vocal fold, for whatever reason swelled. That was exactly what we tried to accomplish in restoring voice. So all of that got better. Then as the swelling went away, it went back to its normal hypoplastic state or non-mobile state. So I would venture that you or the patient, especially you have head turning to improve your swallowing is what's called a supraglottic swallow. It is part of our regimen of getting people to swallow without aspirating. So I'm sorry for inferring things here. It sounds like you were aspirating in addition to having a hoarse voice, and that implies a pretty. Remember I showed you before, the one vocal fold doesn't come to the midline. So if it's stuck out here, like I think yours is, the other one's not reaching it. So food can get into this space, and you can't close your vocal folds to make a voice. So in this case, you can definitely be helped. You can be helped with an injection laryngoplasty, or you can be helped with a thyroplasty. Somewhere in here, I'm pretty sure I saw somebody asking me about reinnervation of the larynx. A number of us have incorporated it into our practice. It requires having an intact ANSA nerve, which most people have, and it requires us being able to find the remnant of the cut nerve, which isn't always so easy. But if you can, and it's not too long of a period, you can rehook up a nerve that will put a stimulus into the voice box. It will not give you volitional speech, but it will bulk up the muscle that's there so you can speak and you can valve and you can diminish the amount of aspiration that you use. Every now and then I break into big words. I like it. I'm doing the Sunday Times crossword later. I hope that answered
Wonderful.
I think that answered two questions. And I
I
think
think
the
it
other
did
one
is,
was from Anonymous. I think I just did that. Okay.
yes. Thank you so much. So let's jump back to Penny. Penny had her surgery in 2019. She's the one who has the trouble with swallowing normally with the head tilted down,
Mhm.
and often chokes. The scar tissue issue again.
Scar tissue is so funny. It's a phrase that surgeons don't use and all the endocrinologists do. I'm not sure what scar tissue they're referring to. Generally, nerves will grow through scar. They don't have a problem with that. The problem is when the surgeon wants to find that nerve in the scar. That's when the nerve gets hurt. I personally have never seen a nerve constricted by scar. Moreover, it's probably some sort of devascularization by us. I think I already just answered that question. I think I just told you that you really should see somebody who can repair that vocal fold. It's not the vocal fold or the nerve that we're really repairing, is we're just pushing around the furniture to get a better voice.
Perfect. Thank you so much. All right, we're going to take this question from Mark. Dr. Myssiorek, Mark Valentine here. Good to see you.
Really?
That's what it says. What immediate and ongoing support do you is needed for patients with thyroidectomy with laryngectomy in restoring the voice after removal or of the vocal cords?
Yeah, for those of you who don't, Mark, this man is a walking, talking miracle, and he blew me away last year. And again, it was one of those people that just made me happy to wake up in the morning. But once you've made this sacrifice, Mark, once he's given up his voice box, I assure you, not willingly, but he had cancer involvement. And I hope I'm remembering this correctly, Mark. If not, you can call me privately and lambaste me. Mark, you're still in London, I believe, or outside of London. The answer is that needs to be seen by a head and neck surgeon. So first of all, a head and neck surgeon should be following you anyway, but voice restoration is getting better and better and better. And we do use voice prostheses. Minimally, you can use one of the electric devices. I'm not really keen on them, but the voice prostheses put in by somebody who does them regularly is just a wonderful, well, it's a good solution. I think people who've lost their larynx, they're a different breed of person, and tough as knives. I don't know what else to say. Yeah, you're in the Mark Valentine fan club here. But that's what you need to do. And you know how to email me. You can email me privately. Let's move a little bit more if we can.
Okay, perfect.
Questions.
I know. Some of them you've already answered in your questions and your answers. Don't worry. Yeah. So here's one.
Here's from hold on.
Oh, go ahead.
The pain is in my right shoulder, and that's the paralyzed shoulder. You need rehab. You need to do things to unfreeze that shoulder. You need to do walking your hand up the wall. But more than anything, this requires physical therapy, because right now, all the weight of your arm probably is 1/9 of your body weight, is hanging off of the tendons that make up your shoulder girdle. But it's doing it all the time. So if you sling it, you'll do better. Now, but sling is not a great solution, on a permanent basis. I personally, and I do see a shoulder surgeon because I'm having some trouble, not the same way you are, but when I rest my arm, when I keep it up on a pillow while I'm reading, it does me a world of good. Again, there are probably things that you can't do, like putting on your coat easily. You probably can't comb your hair easily with your right arm unless you're a lefty. I know I'm an avid tennis player, terrible avid tennis player. So if you want to have a good game and win, I'm your man. After a day of serving, I'm not a happy camper. I won't ever play tennis the day before an operation. Hope that helps you, Rita.
Okay, perfect. Let's take one from Ina or Ina. Is there a point in pursuing treatment for a vocal cord paralysis after a total thyroidectomy done in 1992? She cannot sing or raise her voice and also suffers from voice fatigue.
Yes. I'm sorry, it was a simple answer. Yes. If you're a patient with a complaint and what we offered you in 1992 was status, state of the art, that the state of the art changed in 2002, it changed in 2012, it's changing in 2022. Please seek the attention. Again, even if it's modified voice coaching, I would rather that you saw a surgeon first who could determine whether or not you could be surgically remediated, whether or not, you're not likely to be a candidate for any nerve reinnervation at this point. But there are tons of things we can do. Even a minor injection might get you miles and miles and miles of enjoyment. So that's my strong suggestion. If your surgeon was a general surgeon who did the surgery 30 years ago, maybe you should see an otolaryngologist. If it was an otolaryngologist and he's not retired in 30 years, oh gosh, that's a terrifying thought. You should, I can't, you should consider seeing somebody who will help you. Don't ever settle. Cancer survivors should never settle. Like my bastards, one of the doctors who took care of me, told me I should be happy with an 80% 5-year survival rate. I didn't find that particularly comforting, and I never saw him again. Don't settle. It's your life. You got choices. Do it.
Love that advice. All right, we have a few more minutes, and we're going to take about 2 or 3 more questions.
Well, may I ask real briefly, do we cut off at 2 or 3 more minutes, or is this site going to remain open?
So we will end 5. We can't go over by 2 or 3 minutes because we have to end by 5 minutes past. So we can. No, I mean, maybe it is almost October.
There you go.
But we have we can take about 5 more minutes, and that's as far over as we can go. So here's another question around if a person has seen a speech therapist And we noticed that the voice gets tired and hoarse throughout the day with little improvement in 2 years. Would you recommend seeing an otolaryngologist?
I'm making eye contact finally because none of us on Zoom really look at the camera.
I
Yes,
know.
do that. Do that as quickly as you can, and I would avoid, if you could, and I hope I'm not offending anybody, the doctor that takes care of kids, adults, nose jobs, ear surgery, does the whole 9 yards. If you can get a guy who prefers to see laryngeal patients, you're going to be way ahead of the game. At 2 years, you're still easily remediated if we can. You're the patient. Of course, we'd rather get to you within 6 months, but 2 years is not out of is not out of the range. I mean, there's somebody who I just said go for it at 30 years. So why would I, cheap out at 2?
Mhm. Perfect. Here's a question that I also struggle with personally. So I have one paralyzed vocal cord as a result of my surgery 3 years ago. I didn't type this question, by the way, but I have the same issue. I still experience some difficulty breathing when exercising. Is this common, and is there a way to improve this?
It's common, and there is a way to improve it that you don't want. The way you could improve it would be to do an operation on the arytenoid, which would make the cross-sectional area of your voice box, right? We're breathing through this space. Sorry, but I have very fat fingers. That's what we're breathing through. And when we close like this. The paralyzed vocal fold is like this. But what we can do is remove this little chunk over here, and it leaves a big gap. But the problem is it destroys your voice. So whatever utile voice that you have doesn't do that well. The exercise tolerance is because instead of breathing through this space, you're now breathing through this space. So by definition, you've halved the amount of space you're breathing through, but you got to exercise. I don't have a great solution. The other solution is the one you don't want to hear is a tracheotomy. And nobody wants tracheotomy. The gentleman who's on here would trade his tracheotomy with any of you. Just it's a lot of work. It's a lot of effort. It's a lot of things that restrict you on doing. You can't go, for instance, into a swimming pool, or if you're an avid kayaker and like level 5 kayaking, you may not want to do that with a tracheotomy. So the answer to the exercise tolerance question is it is part of the trade-off that we very rarely address with patients. And you can see my horn kicking in now.
Mm-hmm. Yeah. All right. So a question from Jerry here. How concerning are microcarcinomas for papillary thyroid cancer after thyroid lobectomy not found in highly suspicious nodules? Does it imply possibility of other carcinomas that may not be visible on ultrasounds?
Jerry, you're a pain in the neck.
Yeah.
The whole issue of microcarcinomas is fascinating because let's go back to the original autopsy studies that were done here in the United States. After they were doing above ground testing in Nevada, the plume from Nevada testing went across the country to the Mississippi Valley, up the Mississippi Valley, and across the St. Lawrence Seaway out to sea, where most of the radioactive elements like strontium-90 deposited themselves. However, on the trip up the river, they were contaminating people's lives. When they looked at people who had autopsies for any reason but thyroid cancer, automobile accidents, brain tumors, cardiac stroke, whatever, 5% of the cadavers had thyroid cancer. What does it mean to have thyroid cancer that you didn't know about in your lifetime? It means that you didn't know about in your lifetime and didn't kill you. The reality is that thank God that this is a cancer that many of us survive with. ThyCa would not be as successful as it is. In Hiroshima, the aftermath of Hiroshima and Nagasaki, 30% of the Japanese autopsies were positive. It gives you a good clue as to why it happened. Those numbers are somewhat depressed right now. We're seeing the same rates now going up in Chernobyl. It's 20 to 30 years after. So what the roundabout answer to this is nobody really knows. And this was taught to me by a great surgeon in, George is from University of Chicago, Sisson, who basically said, we know what to do with macro disease. We have no idea what to do with micro disease. And I stick to that to this day. So effectively, if you didn't know you had it, and this is the scenario, people get a 2-centimeter nodule removed. It turns out to be benign, but they find a microcarcinoma, somewhere else in the thyroid. Logic dictates that whatever caused that micro could have caused it in the other lobe. But what logic does not dictate is that we don't need to treat it. I wouldn't treat anything until it becomes treatable. All of you know that being on lifetime Synthroid, with all of its little bells and whistles, as some of my very dear patients have told me and taught me, it's a pain in the neck. Taking Synthroid, it's a pain in the neck. Keeping Synthroid, it's a pain in the neck. Getting the dose correct, it's a pain in the neck. As we get older, our doses change. It's a pain in the neck because it is associated with muscular pain and bone pain, although your doctors deny it. So, and now it's associated with osteoporosis. So having thrown all of that in, I'm simply going to say that I don't know what it means to treat microcarcinoma. And if a patient of mine, I will follow them. I will get serial ultrasound, seeing if something else is cropping up. And if there's signs such as microcalcification, I will take it seriously. But until then, it's a matter of surveillance. And I have to be very careful addressing a group of thyroid cancer survivors. My cancer is different. I don't mean to be cavalier about thyroid cancer. It is not the good cancer. It does have a different set of rules. And those rules change every time we get a new member on the ATC guidelines, on the ATA guidelines. So having spoken my piece, next.
All right. Well, Dr. Myssiorek, we are out of time.
No, we're not.
So
let's just deal. And when we cut off, it'll be like one of those, like the end of The Sopranos, 8th season. Okay, I guess the only wrap up I have is I admire each and every person on this planet who has been struck with a cancer. Except for the cigarette smokers, none of us have asked to get cancer. Every day you wake up, it's a gift. I won't get religious on you. It's just take it as a gift. Make the most of each day. And just remember, it's, particularly this group, we're strong because we have a very survivable cancer, and we're loud because we're not happy with some of the things that have happened to us. I use my pancreatic cancer survivors, I don't treat them, of course, as a benchmark, and that is they've had their own societies and they're just nowhere near as successful as ours because our group is smart. I'm not saying they're not. We have access to the internet and we have a survivable disease. The quality of that survival is what makes ThyCa happen. And that quality is, if I have a chance for a shout out, it's to Gary Bloom, because he made it all possible. And I've known Gary for a quarter of a century now, and we share the same weakness for the Yankees. And I'm looking forward to yanking his chain later. But to all of you, just keep working, keep waking up, and keep looking for something positive every day. Just something, and say thank you to somebody for something. It's amazing what gratitude does. And I'm not talking about your doctor. I'm talking about your spouse. I'm talking about the person who delivers your mail, or in my case, the people who clean up the filthy streets of the Bronx. I say thank you to every single one of them every day when I'm working. And I think that's all I can say.
Thank you, doctor. And we will end the session here.
Thank you so
Sorry I couldn't
much.
stay longer.
Bye-bye.